Happy Sunday. In November, we talked about infusion nurse secrets that all healthcare professionals should know to increase your chances of successful IV sticks. So in today's video, I am subjecting my daughter Ashley to lending me her veins to demonstrate a live cannulation so you can see some of these practices in real time. So let's go. Okay, so in the first video, I went over some of the indispensable things that I've learned over 30 years of practice, namely approaching an IV cannulation with absolute confidence and taking your time. And if you haven't watched that first, I highly recommend that you do prior to continuing with this one. Okay, so the supplies that I'm using today for this cannulation is the 22 gauge BD Safety Intima. And I love this catheter so much because it's completely assembled. There is nothing to attach. The extension already comes attached to it. So you have an injection port right here, which isn't needleless. However, this can be changed out by just twisting this off and twisting on your needleless cap. It actually has one side for any injectables, and then this side, you can actually connect your IV tubing. So you'll see I've added an extension set on the end of this one port just to demonstrate that this can also be done as well if you have a patient that is maybe infusing themselves in the home and needs a longer extension so they can self-access the needleless cap to flush their line or administer their medications. This is a very versatile catheter. If you're using a run-of-the-mill winged over the needle catheter, you'd add an extension set or a needleless cap directly to the female opening after insertion. Another side note, I don't like adding the cap directly because it sits on the skin and can dig in and cause irritation, which makes it rather difficult to access as well. So my advice is to always use an extension set. Now, on this particular day, Ashley's veins were not exactly helpful. They were pretty flat. So my desire was to do a catheterization anywhere but the antecubital fossa, because almost every YouTube demonstration goes right for this area. However, for ease of demonstration, I too wound up going exactly here. So here you see I'm looking around and I'm starting low down by the wrist, and I'm looking at the cephalic, which is normally my go-to vein, but it wasn't really popping up. You'll see she has a few good hand veins, but we really don't want to go there if it can be avoided. So now I stuck a dish towel in the microwave for a minute and then wrapped her whole lower arm in it to try and get those veins to fill a bit. And then afterwards it did pop up a bit more, but the thing with this vein is sometimes it can curve over the radial bone, which hers did. And we don't really want to attempt access on anything but a flat, straight vein. In a perfect world, we don't want to attempt access there. However, more often than not, you will find anything but, usually. But if you can avoid it, as clearly you can see, this vein kind of curves over her radial bone. Normally, if this was an actual patient, then I'd have gone right into this vein. But when you are working with family members, you tend to approach things a little bit differently. Anyway, also make note of the fact that I've placed the tourniquet on the upper arm and lowered her whole arm in a dependent position to allow gravity to help the blood to pool below. Okay, so I've activated the Chlorhexidine scrub here and I'm moving it in a scrubbing motion all over my chosen area for a full minute. Also, normally I'd have gloves on if I was catheterizing an actual patient, but for this I obviously did not put them on. After you've cleansed the area, you do not want to fan or blow on it. Just let it dry on its own. Just let it dry on its own. Next, this is where I'll assemble and prime my extension tubing if I'm using one, or make sure that my IV tubing is primed and ready to go. I also want to make mention of this air vent right here. We would only use this if we're using a glass bottle that does not collapse and needs venting, like in the case of IVIG or some chemo meds come in glass bottles only. So in the event you're using a glass bottle, this just flips open, just like that, and it allows for venting. With these bags, we don't need to do this because they are collapsible and it allows for the exchange of air. So that's what this little guy is for here. So here is where you can also bend the catheter up a bit as you remove the needle cover to help with the angle of insertion if you choose. So our bevel is facing up, so once we get into the vein, the flat part of the needle will glide along the roof, which decreases the incidence of exiting through an unintended deep section of the vessel wall. Now, you'll see that I stabilize the vein by pulling the skin taut from below and actually also pull somewhat to the side. Doing this prevents the vein from rolling or bunching as the catheter makes its initial entrance. I'm also starting at a pretty low angle to my insertion site at about 20 degrees or so. Since this is a small 22 gauge catheter, the bevel is only about 1 millimeter in size. So once I enter the vein and see flashback, I lower the needle angle even more and advance about another 3 millimeters or so before pushing the flexible part of the catheter the rest of the way in until it's completely seated. Here I advance a bit more than that before I pull back on the end to remove the stylet. Quick rule of thumb is to look at your catheter size to know how far to advance the needle to make sure it's seated adequately in the vein. A 22 gauge has the bevel size of about 1 millimeter. So we want to add another couple of millimeters to account for not only the bevel, but another couple of millimeters to make sure that a sufficient amount of flexible catheter is also in the vein. Otherwise, you may puncture the vein successfully, but not have the actual catheter in there yet. And as soon as you remove the needle stylet, you have no blood flow and you can't advance the flexible portion at all. This can be tricky and one way that a cannulation can actually fail. Continuing on. Once you're satisfied you're seated in the vein, you want to remove your tourniquet prior to removing the stylet. This is a mistake you will only make once and never again, because this will cause that vein, which is under pressure, remember, to bleed quite a bit more and make a mess of your site, which can then make the rest of your procedure kind of difficult because you can't see. Not to mention the cleanup before you can actually put a dressing on it. Then you're going to flush your catheter and look for any signs of infiltration, even though you should have a pretty good idea if you have a nice vigorous blood return and the patient's not complaining of any, pain when you're flushing. That's always a sure sign for me, is if I start to flush and the patient goes, ow, that really hurts. It's telling me it might not be in there. But this is what you're looking for. You want to make sure that the catheter is in fact seated. It maybe didn't go through a sidewall and you're still getting some blood that's pooling around the area that as your flashback, it can happen. And actually during my prep, I'll have already ripped my tape usually, but in the event, this is the point where if I hadn't, I would then rip my tape in half. I would just take a piece of the tape that comes in the infusion kit and it rips very easily. I rip it in half and then I do what's called a Chevron. It holds the extension set nice and securely. So if you found value in this video, hit like and subscribe, as this really, really helps us to continue to grow, and those that may benefit from this information can actually find it. And if you have any questions about this procedure or any of the supplies I used, drop a comment below and I'll be sure to address them. With that, I'll see you on Wednesday.